welcome, and thank you for having me. And thanks, Lee and Donna and JFK, everybody else who helped organize this, and Ellen for being here, and everybody else who's here on their off day to be listening to this. We've been talking about this for a while, where we've seen a huge upsurge of the Indian population at JFK, and there are a lot of cultural issues that come up, and how do we take care of them? And I know we've had some side consults, people pulling me and saying, how do you do this, or why do they do this? This is an effort to try to make it a little bit more understandable where we are coming from. So I was born in India, but I've been in the US for almost 40 years. So, but I still have, my roots are still pretty strong, and that's why I think I feel I'm capable of talking about this. We have a nonprofit organization called SKN Foundation, which promotes health education throughout the community, mainly focusing on the South Asian population and bringing that sort of information out.
I want to see
Probably the other light, I think. The front one, maybe? Nope. There we go. And I hope that doesn't put you off to sleep, but don't hesitate to stop me. I don't bite. If you have any questions, anything that you don't understand, I'd be more than happy to answer for you. I am obligated to tell you this. I have no financial disclosure. I don't get paid for coming out here and doing this. We do this as a passion, and Ellen, thank you for having me here. You do need to fill out the evaluation forms, which you've already heard about. So some of you guys who are already in patient care, some of you guys who are learning, and just getting exposed. Let's start off with just some discussion. An Asian Indian patient checks in, and what are the thoughts that come to mind? Some of the people who've been, I know, have told me this offline, but if you want to share some of your experiences.
Will the patient answer my questions, or will she look to her husband to answer the questions and direct her care?
Very astute observation, and we'll be talking about that. Anything else?
Does the patient speak English?
Okay, does the patient speak English? But that can be true for a lot of different races, right? But that's a key thing. What else?
Are they going to ask to have so many people in the room beyond what we usually allow?
Right. A lot of people in the room, so there's a party going on, and we'll talk about that as well.
Is it going to matter who provides care, whether it's a male doctor or a male nurse?
Very good point. Very gender specific. So these are a lot of things that come to mind as soon as we see a patient. So are these stereotypes, or what is a stereotype, if you want to define that? Any thoughts?
It's certain behaviors that you associate with a certain group of people.
Right. So are they positive or are they negative?
It could be either way.
It could be either way. So stereotype is a preconceived notion that you come in with that leads to generalization. It can be discrimination in a positive way or in a negative way. So you come in with all these thoughts that, oh my God, will there be lots of people in the room? Will they understand? Who will answer? These are all things that we have stereotyped this population for. So who are we? And why do we need to learn about them? So if you look at some of the data that's come out, especially the report that came out of the Department of Health in 2009, said that India was the leading country of origin among the immigrant population in 2009. So amongst the foreign-born, it even surpassed a lot of the Hispanic community that we think is the largest immigrant population. And the majority of them are foreign-born. So we aren't born in this country, but we come in, being born in India with a lot of our strong cultural roots that we have. Who are Asian Indians? So this is a map of India, and the government in itself in India has divided the country into 7 cultural zones: north, south, east, west. But what does that mean? So within one country, there are a lot of different cultures that are there. So I'm from the north. People from the south may be very different. So what this is alluding to is that even though we're learning about Asian Indians, there are a lot of different diversities that are within the country. So you cannot really understand and learn about everyone all at once in one small lecture. We're considered to be a model minority. We have a very high income, one of the highest median incomes of any immigrant groups. And we're one of the most highly educated. At least 60% of us have a bachelor's degree by the time we're 25 years of age. And how did that happen? There was a trend in immigration. In 1965, the Immigration Act led to a huge influx of highly skilled and educated workers. And as part of that Immigration Act, there was a secondary provision where a lot of the family could be reunited. So what we're seeing now are those family members who may not be highly skilled or educated. So that population is coming in. So you have now a divide. You have a highly affluent segment of the population, and then you have the highly, they're skilled or unskilled family workers that are migrating in. So as I said, are we all the same? No, there are a lot of different things here. So if you look at religions, there are multiple religions that are practiced. There's multiple languages that are spoken. But the degree of acculturation and assimilation to the Western society really depends on how long we've been here, what our influences have been, and that is what's going to determine our healthcare seeking behavior. Because our healthcare beliefs coming in from India are very different than when we are here. So there are 22 recognized national languages. There's over 700 spoken dialects. And Hindi is the national language. And Gujarati is the second most common language, but one of the most common spoken languages in New Jersey. But most of us do speak English, especially if it's spoken slowly. Religion, it can be the central part of life, or it may not be. And the most common religion that you're going to see is Hinduism, but there are a lot of other ones that are practiced: Christianity, Sikhism, Islam, Jainism. So if you look at Hinduism, that's one of the most common languages. There's a strong belief in karma, that what happened in my last life, there's a belief in reincarnation, is what is going to impact what happens to me in this life. So this can lead to a fatalistic view. Oh, why do I even bother? This is my karma, so I'll deal with it the way I want to deal with it. And whatever I do in this life is going to impact my future life. So, if I have cancer now, that's my karma. So I don't have to deal with it, or I do have to deal with it. So that can become a very strong belief that can impact how they take on the disease. There's a lot of rituals, meditations that are practiced. There's a bindi that's worn by a lot of the Indian women. There's a black tikka that's put on the kids. And these are all practices that have a significance behind it. You can be the follower of Islam. And in Islam, Allah is the one God. And you worship Allah at least 5 times a day. So that can become an issue when you're trying to make appointment times. Why can't you do it this time, or why can't you do it that time? Well, that's my prayer time. And if there is a prayer time, I need to find that place to be able to do the prayer. I need to put my mat down and I need to do that. There's fasting, and there's a whole month of Ramadan where fasting occurs. So if you're asking them to take certain foods in the month of Ramadan, that can be impacted by what they're allowed to eat, what they're not allowed to eat. Covering of the head is very key. So a lot of the kids, a lot of the women, they will cover their head. And having them move that cover from their head can have a big impact and significance on how they look at you and how they deal with you. Sikhs, same thing. They'll wear the turbans. There's a very strong belief, there's 5 Ks, the articles of faith. One of them being the kada, which is the bracelet that the kids or everyone wears. You cannot take that off. There's the turban. You should not take that off. They never cut their hair. So these are going to play a role when you're trying to go through surgery, or trying to get them to move their turban. What are they allowed to wear by hospital regulations, what they're not. Buddhism, very peaceful people. They want to attain nirvana, the ultimate reality. And their beliefs are life can be a suffering, but you need to know how to deal with that suffering. So very calm and quiet if you're practicing Buddhist. Jainism, very similar. Believe in non-violence, being truthful. So you have lots of different religions, you have a lot of different languages. How do you communicate with such a diverse group of people? So here we have an Islamic group here, we have a Sikh, and we have a Hindu. How do you greet? Hindus may say Namaste, Muslims may say Assalamu Alaikum, and Sikhs might say Sat Sri Akal. Everyone has a very distinct way of greeting each other. Physical contact usually not customary, especially when you're greeting a member of the opposite gender. So I wouldn't just go ahead and shake the hands of another woman that's coming into my practice. Customary to talk about meeting again at the time of leaving, because everything needs to be a continuum. So social smiles, usually between equals. So I may not smile, or the patient may not smile at me because I'm considered to be superior to them. They may use a lot of head shaking and nodding, which you've seen, and I'm sure you've seen lots of jokes around it.
I have to tell you, it took 15 years for me to figure out what the head shaking is. Nobody shares that.
Right. So you can shake a head. It may mean yes, it may mean no. It just is an acknowledgement that they heard you, what you had to say. And you could be totally silent if you're listening to somebody. It may or may not signify that you've accepted what they're saying. It is just an acknowledgement that you are telling me something and I'm listening to you. Especially if you're somebody who's of a hierarchy, that you should stand if that person enters the room. For Hindus especially, the foot should not touch the paper or food or another person. So you don't go around and say, hey, you don't step on paper. How do you use interpreters? Interpreters for elders by youngsters is going to be very limiting, because the youngster is not going to translate a lot of the terms, a lot of the things that you may want them to, because of that hierarchy. And we'll get into that in a little bit as well. You can use the AT&T language line, but it may not cover hundreds of your dialects that are out there. And it's not culturally sensitive. Discussion of private mental health issues and sexuality issues can become a challenge, especially when you're using a youngster for interpretation. And same-gender translators are preferred. Family communication. Every family member wants to know what's going on with that patient of yours, right? So you tell them, the patient, something, and then you have like 20 different family members who come in and want to know what's going on, what's going on, what's going on. Now this becomes an issue, especially at the hospital setting, because of HIPAA compliance and privacy. So how do you involve them? How do you engage them? That is one thing that you'll have to deal with case to case. So what is the family structure like, and how does that impact? You have multiple generations that may be living in the same household. Respect for elders is highly valued. So whatever the elder says is usually what we would go ahead and do, even though we may not like it. And families tend to be private amongst themselves. Grandparents may be the primary caretaker, and the family honor is the foremost. So whatever the family is going to be maintain their dignity is what is going to be done. So when you have a big party in the hospital room, and you have the grandparent there, and the mother there, and this person and that person, whoever is the eldest, that is who is going to make a lot of those decisions. You have spousal gender roles. You have husbands who typically take care of the external, and wife who rules the house. But as you pointed out, that when you're talking to the wife, the husband is going to answer. The wife may look at the husband for him to answer. So what do we do as providers? We need to empower the wife to make sure that she talks. But a lot of times, no matter what you do, you talk to the wife and the answer comes from here. So you expect them to answer, but once again, if you're trying to get that privacy answer or that private answer from the wife, you may have to separate them out to get the right response.
Dr. Mehrotra, how do they feel about that if you do say to them, I understand that you are answering for your wife, but I really, as a healthcare provider for her care, I need to know how she feels. How does the man, the spouse, interpret you then as saying that? Like, is it more of a standoffish, well, who is she to say that to me? Or, you know, because really, a lot of times, the women doesn't want to say how they truly feel because it's not what he wants her to say. Like, how do they interpret it? Do you get
Yeah, they're going to look at you disrespectfully, but you have to do what you have to do.
Okay.
So if you need to interview the wife separately, you have to tell them, excuse me, I need to do this alone
Okay.
with her. They won't like it, but you have to do your job. So,
I choose my battles. If that's
Yeah.
if that's their family set up and the husband is the one who's gonna answer, I look at her and ask the question and he answers and I write down the information. That's it.
right. So if it is critical, you have to push it through. Same thing with the HIPAA compliance issues. If it's critical, you have to go ahead and tell them, this is the law, this is the way it needs to get done, I'm sorry I can't tell them, but I will tell you and you have the right to go ahead and tell everybody else. So the elders that are in the room, the mother or the mother-in-law is usually present at the time of the delivery, right? And respect for elders is highly valued. And you'll always hear that, the concept of my time, this was the way it was done. Don't tell me otherwise. And the daughter-in-law will have to listen to what the mother-in-law has to say. Once again, these are some guidelines. These are not absolutes because they do vary from family to family. It also depends on assimilation, acculturation, and how bold the person is to speak up.
I was just gonna say, earlier when I've been at JFK for over 10 years now, but earlier when I got here, a lot of the times, you knew the patient was in extreme pain and they needed something, but then the mother-in-law or the husband would say, oh no, they're fine, they don't need anything. And like, the woman is like looking at you, it's almost like, help me, you know what I'm saying?
Yeah,
it's like,
sure.
but they are the ones that are
They're dictating, right.
the rules. So like, it was like, okay, what am I gonna say? Well, you know, your wife is in pain. I know if she really needs something to get over, you know, I try to talk to them to convince them that it's okay for her to take the pain medicine.
Right, so you will have to do what you think is the best for the patient. So if they're adamant about it, really trying to talk to them and say this is what needs to get done. And then maybe trying to catch the wife separately and ask her,
Yeah.
hey, it's okay to take the medication. And empowering her as much as you possibly can when she's alone is what's going to happen. Because otherwise, as soon as you leave, they're going to all come down on her. And then she has to deal with that wrath.
I think the worst thing to do is to argue with the family.
Yeah.
That really sets it up for disaster.
Because as soon as you do that, you're going to alienate them. And that is where you're going to lose compliance. Because as soon as they're out of your sight, they're going to do what their family structure dictates them to do. So that is what the purpose of, one of the main goals of this talk is, to try to understand where we're coming from and see how you can bridge the gap.
If the mother-in-law's role is so important, where's her mother's importance in it? Does her mother play any role in it at all?
No, the mother-in-law will have priority.
Mother-in-law.
Yes.
Okay.
If the mother-in-law cannot make it, then the mother may show up.
Okay.
But if they're coming in from India, the first person that's going to be given priority is the mother-in-law. And we'll get into a little bit more on that in just a little bit. So extended family members, they try to live nearby and they'll also come in and sort of give their opinions as much as they can. They will offer advice as freely as they can. So you should do it this way, or my doctor does it this way, why didn't you do it that way? And your doctor doesn't know anything, question them this way, the nurse doesn't know this, and all that. So the more people you have, the more advice the patient is going to get. And then they're going to have to deal with all of that that's coming into their mind. And once the mother-in-law comes, she stays for a few months. She might stay for about 6 months. So right in the peripartum period, right at the time of delivery, she's there, and then she's going home with them. She's staying home with them for a few months. So that is a very stressful time for the mom. So if we take a clinical scenario here, PW is 20 weeks pregnant. Her regular medical checkups had started at 6 weeks. We're very good with our prenatal care. 20-week ultrasound reveals that she's going to have her first baby boy. Upon hearing this news, her mother-in-law decides to come and stay with her and take care of PW until she has the baby. Every day she makes special sweets and delicacies with lots of nuts, butter, and special condiments. Any thoughts? what
Hope
is
she
the
doesn't have
scenario?
gestational diabetes.
Okay.
Right.
What else?
I think she's a wonderful person.
Great. I love your positive attitude. What else?
Do you think that the girl who's pregnant feels invaded by this person coming in?
Sure. What else? Some of the other
To
key
my
things
house
that
to
come
cook
up.
for me.
Anything else that comes up on this? And this is a very real scenario.
Is it because it's a baby boy?
Thank you. First baby boy. So first baby boy, it's very key, right? It's somebody who's going to carry on the lineage. Mother-in-law is so excited, she's going to come in here and pamper her or hover over this daughter-in-law until that baby gets born. So that's a typical scenario. So when you have the husband and wife there for the first time, how do you discuss sexuality issues? How do you deal with that prenatal care part? Sexual health is very often considered a taboo subject. We don't talk about sex at all in the household. Sex education is uncommon, not something that's routine part of education in India. So a lot of the terminology that you may use, unless that person is acclimated to those terms, may not know what those terms are. And routine pelvic exams are really not common. And they're very traumatic if that's the first time they're getting it done. So they may not have ever had a pelvic exam. They may not have gone to an OBGYN. They got married, they come here, they have their first pregnancy, and that's the first time they're going to see an OBGYN doctor.
It's a huge issue at family practice.
Yes.
Because we have patients coming in and all of a sudden their doctor is half female and some have walked out. And we try to accommodate as much as we can. And some, will talk to them, their husbands, they'll talk to the husband. And a few of them will agree to a male doctor, but most cases,
Right.
that just doesn't
So
happen.
we would prefer the same gender physician. And it's the same for guys as well. So guys would prefer a male physician. Women would prefer a female OBGYN.
I think we see that the sexual education part of it a lot in labor and delivery because we have to do vaginal exams. That's the only way we know whether they're dilated or not. And
Right.
it can be very, very traumatic for the woman. It's very difficult. So we see it in that regard.
Right. So might be the first time they've ever had an
Right.
exam. And you have to be aware and you have to be understanding of that. First of all, they're not used to having somebody touch them down there.
Right.
And secondly, oh my God, they're laying there naked. It's very, very private for them. And married couples will learn through experience, right? So that's the first time they may have ever had a sexual encounter when they get married. And even that, it's something that you learn over time. Details of the childbearing process, it's totally unfamiliar. We don't talk about it. Even when you're in India and you've had babies that have been in the family, the male will not go to the delivery. So when they are here and you expect the male to come into the delivery room, it can become a big issue because they've never gone into that environment. And especially after the birth, if you start to talk about contraceptives, men will not be readily using contraception. It's something that they believe that the woman should be doing. Especially if you're talking about permanent family planning like vasectomy, it's not something that would be considered for a traditional Indian male.
Are they receptive to birth control pills?
They may or may not be, but definitely it would be thrust upon the woman, but the woman would then ask the husband, and then the husband would decide.
Okay.
But using condoms or vasectomies or anything along those lines from the male side is not something they would readily want to go ahead and do.
So if they're not using condoms, is it like sexually transmitted diseases? Is it rampant?
Nobody knows, but if they are having relations outside, yes, we would expect that. But here, hopefully, I think a lot of the families tend to be intact, but nobody's really studied that here. So the belief is that if you're married, you stay with that person for the rest of your life, and that's your only sexual partner.
So divorce is not a common situation?
It's not a common situation, but lately as we see the Western influence coming in, divorce is on the rise even, mainly in the cities, but definitely if you're out in the outskirts of the cities, it's not something that's looked upon favorably. So once you're married, and that's it. So even if your spouse passes away, you don't remarry. So usually in the traditional sense is what happens. Health disparities, a lot of different health disparities which you guys already are well aware of, and you know that incidence of gestational diabetes is much, much higher. And I think one of the things where we lack on the education on the diabetes part is a lot of those women that have gestational diabetes will tend to keep that diabetes even later on in life. So they will go on to develop type 2 diabetes. So we need to make sure that they are told that they need to follow up with their primary care physician for the next few years and be checked for diabetes. And we also know there's a higher proportion of infants that are born with low birth weight. We don't know what the outcomes are on that long term. If you have an SGA baby, is there any sort of an impact? We don't know. But there is a much higher incidence that's been reported and that's been studied well.
Have you found that the babies are larger now than they were, say, 10 years ago? You know, based on them eating the fast food here, and what have you?
We have not looked at those trends in terms of the actual weight gain 10 years ago to now. What we have looked at, and I was just part of that study as well, is we just came out a few months ago, looking at all the deliveries in the state of New Jersey and looking at the Asian Indians. We had a much higher incidence of lower birth weight compared to the other population, but we were not able to, because about 10 to 15 years ago, a lot of the birth data was not reported with that field where people would populate and say Asian Indians, and you could extract that data out. So it would get lumped into Asians or other, and we just don't have that data to look at that.
Is hypothyroidism also a higher incidence in Asian Indian? Because we're seeing a lot of the patients coming with hypothyroidism.
Right. We know that anecdotally, but we have not looked at it as a study. So much higher incidence of thyroid abnormalities in the women, in the Indian women. Thalassemias, a much higher incidence of being a carrier. So a lot of us have, the genes for thalassemia which get transmitted. So the newborn state screen, you do it, but you don't have to follow it up. We end up following it up in our office. There's a much higher incidence of being abnormal and needing to get followed through. Hepatitis A or hepatitis B carrier, especially if they're a recent immigrant, you need to look at that. We see hepatitis B in a much higher incidence in the Oriental population as opposed to the Asian Indians. Tuberculosis, higher incidence of positive PPDs. A lot of us have received the BCG vaccine in India, and that cross-reacts. So when you end up doing a PPD, it turns out positive, and we end up with chest X-rays, getting treated with INH, and that whole scenario. But now I think with the advent of quantiferon gold and some of the other tests that are coming up, we're starting to look at that where people may not need to get treated. Gender selection, genetics testing and ultrasounds can give the sex of the child early on. It's something we may want to know, we may not want to know. We're not supposed to know, but if we know, we would prefer to have the male child because that child will go ahead and carry on the family name. There have been reports of selective abortions based on finding out the gender. Fetal deformities and demise. Disclosure of an abnormal fetal ultrasound really causes a lot of stress, right? There's something wrong, or there could be something wrong, because we want that perfect child that's going to carry on the family name. We want to make sure that everything is good. And the thing is, if there is something that's been abnormally reported, oh, we're doing the ultrasound, we think there's something wrong, but we're not sure yet, it's going to read in like 5 days. Those 5 days, they'll be calling you left and right, or those 4 days are going to be calling you again and again. Did you get the results? Did you get the results? Did you get the results? It's highly stressful, so we want to know the results right away. Pregnancy is supposed to be a happy time. You protect the mom from strain and stress. You want to go ahead and make everything, very nice and cushy for her. The fetus is susceptible to the evil eye, so you want to make sure you protect the fetus and the mom as much as you can. Beliefs like the solar eclipse or the lunar eclipse, you go out into that time frame, you can actually affect the fetus adversely. There's a lot of ceremonies that happen during this time to make sure that that baby comes out right. Dietary habits, they also play a big role in how we deal with that pregnant state. A lot of those healthcare practices and beliefs come in from Ayurveda, which is, if you translate that, what it means is the science of longevity. It's an inherent part of our life which gets started from early childhood. How is the food? What is the food? How is the food taken in? What time of the day the food is taken in? Those are all very important factors that come into play to make sure that we stay healthy. And elimination of waste, so defecation, is crucial. I haven't had a bowel movement yet. Oh my God, I haven't had a bowel movement yet. That is a key thing, especially right after a pregnancy, right after delivery process. We're so fixated on that because if you don't defecate properly, your body is not going to be healthy. So there's hot states, cold states. Pregnancy is a hot state. You want to avoid a lot of that meat, eggs, and spices because it's going to make your body even hotter. You eat lots and lots of ghee, which is purified butter. That is what's going to make the baby healthy. But it's also something that's going to make you gain a lot of weight, which becomes harder to lose once the baby is delivered. And the mother or the mother-in-law, whoever's there, will make fresh meals. She will bring in that food from home, for breakfast, lunch, and dinner, to make sure that the mom gets the best food that's there. So that was they've gotten pregnant, we've dealt with all of their issues. Once they come into the hospital, what happens? They check in. We tend to be quite subservient and may not openly question what the physician's asking. They'll just say yes, even though they don't understand. They may think about it afterwards and then they may come back, but they believe that the physician knows what's best, and the physician's decision is what they should go by. Or the eldest male in the family is the person who's going to go ahead and decide. So if you're deciding between 2 or 3 different things, they will consult amongst the family before they decide. Hospital visitations. Family involvement in patient care is expected. So we see that the whole family comes in and somebody wants to do this, somebody wants to do that, but anything else the nurse can do, but taking care of that patient is what they want to make sure that gets done. So visiting hours, really, we don't want those. We want to be here 24/7 with the patient while we're here. So don't tell me to get out at 8 o'clock, I'm not leaving. Okay, relatives, they'll keep on coming. You'll have somebody coming in at this time, that time, bringing in food, once again having a party in there.
Is that how it is in India? They don't have like visiting hours, it's just 24 hours, they come anytime?
So what happens in India is that a family member stays with that patient 24/7. So they will stay, if you're on a cot there, and somebody will camp out on the ground for you. So you can take them to the bathroom, you can do whatever else. You can be their personal attendant. So that is what they expect here.
So sleeping on the floor is normal for them? because
It's normal for them.
We walk into them in the middle of the night when I was working nights, and they'd be spread out on the floor on a
Right.
blanket.
Yes.
And you're like, okay.
Whatever space we find by the patient, we will go ahead and put something down and we will lay down there. Because our role is to make sure that we're there at the beck and call of the patient, because we want to make sure that the patient's care is optimized so that the patient can go home healthy. A lot of food requirements. Okay, Hindus, vegetarians, they may or may not eat meat, but most of them don't if they're vegetarians. May not even eat eggs. Beef is strictly forbidden against the religion. Muslims will not eat pork. They may want halal meat. And Sikhs may be vegetarian. So each religion or culture will have their own food requirements. And I know now that the hospitals have started to offer different types of foods, The variety is better, but definitely still there are a lot of nuances that are there. So if a capsule is a gel cap, they may not be ready to take that because the gel cap has gelatin in it. Or if certain vaccines, they have some sort of an animal byproduct, they may not want to take that. Or they may want you to know that answer so that you can give that to them and then they make that decision. Once again, our dinner time, 5:30 or 6 o'clock, that's our tea time. We're not eating dinner at that time. So most of the trays that come in at that time usually get returned like that. And then the parent or whoever else, the family member, will bring in the food so that we can eat at our regular dinner time, which may be 8 o'clock, 8:30, 9 o'clock. And then if you're telling me to get kicked out at 8 o'clock, that's not a good time because that's my dinner time to be with the family. And then they want, bring the food in, then they want to use the microwave, and then the microwave smells up the whole, the food smells up the whole hallway. Labor and delivery, we touched upon it already. The mother or the mother-in-law will usually be at the time, at the delivery, but not the father. The father just doesn't want to be in there. It's not something that he wants to deal with. And the pain can be dealt in different ways. As you brought up, a lot of them may be expected to not shout about the pain and bear the pain because that's what they're supposed to do. If you have a chronic figure,